first panelist, John Ankrod. John is a flight respiratory therapist, a registered respiratory therapist, and a adult critical care specialist. He works in the Department of EMS and Flight Medicine at ADVENTHEALTH in Florida. So John, I'm going to have you take it away.
Thank you, Winnie. I just want to give a shout out to you and to Ed and to Draeger for getting this together and inviting us. I was lucky enough to be on the discussion a few weeks ago when we had the physicians from Wuhan, which was very informative. So it was kind of nice that we could expand from that and bring some of this conversation back to the US side and kind of get to know about what's going on in the transport world, what's happening in Kentucky, and Rob will be on later to talk about some things he's doing out in Seattle. It's unfortunate we didn't get to hear Dr. Kaufman today, so we certainly will miss him, but hopefully you guys will forgive him and we'll get started with me. As Winnie said, I've been practicing for 27 years as an RT. I've been with Flight for 7 and Advent for 8. So it's been a fantastic career, and like I said, it's like a bottle of wine, just gets better with age. So I'm hoping the next 20 plus years is just as good. So we're going to talk about the critical care transport of the COVID-19 patient, and I know that the title talks about extended transport of these patients, and we're going to talk about that later briefly with a patient that we took on a jet. But first off, we're going to get started with talking about some of the things that are happening here in Florida, and certainly Central Florida, and some of the statistics that we're looking at, and of course what we've done at our institution from a transport side. So we will move forward. I think I can figure this out. All right. So this is ADVENTHEALTH Orlando. This is kind of where I hang my hat. So this is where we are based out of. This is kind of the mothership of the ADVENTHEALTH system. We are a 44 hospital system based in 10 states. We service over 5 million patients annually. ADVENTHEALTH Orlando is considered one of the largest, if not the largest, hospital in the United States. And you know, this can go back and forth, and it's all about numbers. But I just kind of throw that out there because we are certainly a huge facility. We take up about 14 city blocks, about 3 miles north of downtown Orlando. And we were voted by U.S. News and World Report as the #1 hospital in Florida, so that's certainly an honor. We have some fantastic institutions in this state, from Miami up to Jacksonville and Mayo and Shands and UF and Tampa General. So we certainly have some great representation here in the state of Florida. We are a large tertiary care center. We do get patients from all over the Caribbean, state of Florida, even the southeastern U.S. So we see a lot of folks. All right, this is my bird. This is the only aircraft that we have at ADVENTHEALTH. It's been not this specific aircraft, but we've been around since 1985. This is our 35th year, so we are very, very proud of that. We certainly would like to have a second helicopter. I don't know if that's going to happen anytime soon, but that is certainly something that we are looking at, is getting a second aircraft. So we are currently a single aircraft program. We fly the EC-145, which is pictured there. We are vendor is Metro Aviation. We've been with them for 15 years, and we have 15 team members, 9 of which are nurses and 6 are respiratory therapists. And we've flown that configuration since the inception of this program, and it's just worked for us because we are a very heavy cardiac facility, and the RTs in Central Florida manage the balloon pumps, and that was kind of how this all got started. So we have been on the ship since its inception in 1985. Our heli-op services, and I put that there because we, again, we've gone into Georgia, into Atlanta and Macon and some of the other southeastern parts of the U.S., picked up patients via fixed-wing aircraft. But from the helicopter perspective, we pretty much deal with just the main portion of Florida, except for the Panhandle and the Keys. We just don't go that far. We don't have the range to go that far in this aircraft. So, but we do go to Jacksonville and Shands and Tampa and Naples a lot, Miami. So we're kind of all over the place. And then our EMS system is about 10 years younger. They started in 1995. This picture up on the right-hand side, just kind of keep that in your mind because there's a story that goes with that image. But yeah, just kind of keep that in your mind. We have generally in a shift 5 critical care and 4 NICU peds and a hybrid truck, which can do NICU and peds, and about 10 to 12 ALS trucks per shift. We have 25 ambulances in the fleet. about 250 staff. We do about 40,000 calls on an annual basis. And the service area for these guys is the entire state. Very, very proud of our folks when they went up to the Panhandle after Hurricane Michael and kind of helped out with some folks up there, because that place up there in the Panhandle was devastated. So we certainly made our presence up there and helped the best that we could in that situation. And so far this year in this COVID crisis, we've done close to 500 transports, and admittedly, a vast majority of those were done by ground. So we'll talk about that when we get into the heli-ops part of this. So Florida statistics, sorry about the phone. Florida statistics, this is much worse now. And I shouldn't say worse, but the numbers have certainly increased. This is about a week old slide. I think it's the 5th of June. We are well over 70,000 cases in the state of Florida as of today. We have gone over 2,800 fatalities in the state due to COVID. So we are starting to see that second spike, if you will. You can see here on the map just kind of the coloration of the counties. Orlando here is the Orange County is right here. Hillsborough is Tampa, and of course the Southeast Corridor, where Palm Beach, Fort Lauderdale, and Miami have over 50% of the state's cases. So Central Florida has really, and I'm going to get into that in the next couple of slides, kind of dodged a bullet, if you will. But right now we're over 70,000 cases, over 2,800 deaths, and over 11,000 hospitalizations. So when you look at this, kind of just a very basic slide. This is as of yesterday. This is the Central Florida region. These are the 4 counties that we kind of consider just the mean area of Central Florida. We could get into Daytona and Melbourne and Lakeland and Polk County, but that's really spreading out our wings. But so we're going to keep it right here in just the main portion of Central Florida. So Orange County, where Orlando is, has the majority of the cases, as you'd expect. Kind of give you there our fatality rate. Over half of these patients were male and a 61-year average age. Again, you guys can kind of look at this slide. I don't really need to belabor the numbers here, but certainly you can kind of see where we are in the region. Oops. So let's talk about Central Florida for a second, and just the vast amount of people that we would see generally in a normal year. 77 million people come to Central Florida annually. That's pretty much the southeastern United States, roughly, minus a few million. We have the busiest airport in the state with 51 million people. Orlando itself, the metro, is about 2.5 million people. We have about 5,500 hospital beds within the region, with 500 ICU beds. So my point to this slide is just how amazingly worse this could have been for us. Shutting down the things when we did, and there are, we're not going to make this political. There are pundits out there that talk about keeping things open, and I understand that, but at the same time, with the amount of people that come through here and from all over the world, we could have certainly seen things a lot worse. And to be quite honest with you, I just don't know if we would have had the capabilities to withstand that. Fortunately for us, as you can see there, we're doing about 4,500 COVID positive patients, a little over 700 hospitalizations, and as of yesterday, just 94 deaths. And for a comparison perspective, if you look at Detroit, which is about twice the size of Orlando, they had almost 6,000 deaths. And then you look at New Orleans, which is half the size, and they had over 2,500. So, again, we are very, very fortunate, but again, we are still now seeing these ebbs and flows. We have not seen a very big spike in hospitalizations at our place, and I think our sister folks across town, Orlando Health, they have not seen a very big spike in their admissions either. So that's good. So my colleagues in the respiratory department in Orlando, these numbers are about a week and a half, 2 weeks old, so they may vary a little bit, but not much. About 110 mechanically ventilated patients. Their max load was about 71 over 3 ICUs, and that was on April the 5th, as this was really ramping up. Again, we talked about the male kind of having a little bit more cases than the females and the average age. About 12 and a half days on the ventilator and 16 in the hospital. Our mortality rate was about 18%, which when you look at things, considering that some parts of the country had a much higher mortality rate than that, again, we were very fortunate. And I just spoke with actually one of our ECMO coordinators. And when I made this slide, we had 13 total. We still do, and we had 7 discharged, 3 that were still cannulated, and 3 fatalities. Everybody's decannulated, and we still have a couple in the hospital. But I think she said that 8 or 9 have been discharged, so there's just a couple hanging out. So a 77% survival rate for those patients that had to go on ECMO that were COVID positive. So it's kind of impressive too. So just a quick pie chart here on kind of what we've done on the EMS ground and flight side. About 485 transports. You can see a 3-to-1 ratio there on negatives to positives, which is good. About 60 of those patients were ventilated and 4 were proned. Again, admittedly, none of these folks were proned in the aircraft. All of our patients that were flown via the aircraft were flown supine. All these patients that were proned came by ground. And again, from the flight side, you know, on a national level, I don't think that a lot of rotor programs did a massive volume. You will find some around the country. I think Boston Med Flight and Survival Flight in Michigan did a lot of cases via air. But from the most part, our sister programs around the state were kind of like us. They just didn't do a whole lot by air. If they could get them to the centers by ground safely. So there are some logistics we're going to talk about here shortly. You put them in a helicopter or in a jet. So again, a lot of the stuff at the bottom doesn't mean much to you guys, but these are all of our locations going up to ADVENTHEALTH Winter Park. These are all of our ADVENTHEALTH campuses going from Sebring up to Altamont Springs and Daytona Beach. Most of these bigger numbers are standalone ERs. So you would kind of expect that. I mean, if you have a ER facility that just can't handle patients like this, obviously they don't have an ICU, they don't have the staff. They're going to get shipped out to other places. So ADVENTHEALTH, Lake Mary is one of our newer ERs. Oviedo is a brand new ER. Waterford Lakes is a brand new ER. So again, these are very, very high volume amount of patients that are coming out of there that we were transporting. Again, all of these folks, I believe all of these folks came by ground. If you look over here to the right side, these are some of the other referring facilities that we go to. I'd say frequently, but we go to them throughout the year. St. Joe's and Tampa, Naples Community, we do go there pretty frequently. Lakeland Regional, Exec. I want you guys to keep an eye on that because that goes with the story about the ambulances. 9 patients came out of Executive Airport here in downtown Orlando, and I'm going to tell you that story here shortly. So let's talk about transporting these patients via helicopter. So when this all started to ramp up, we kind of had a stand down. And I don't want to say it's an industry-wide stand down, but I will tell you from our vendor, Metro Aviation, a lot of our programs, we were having weekly conversations online about what we were doing as programs around the country to treat these patients and obviously to keep us safe and our pilots safe. So we kind of had a brief stand down of how we were going to go about this, and we came to a conclusion that we were going to take these patients if they were ventilated, taking patients that we knew were COVID positive by air that were not intubated, kind of just added a whole nother dynamic to exposure. So we involved our communication specialist in this as well. If they got a call about a patient who was either under investigation or a positive, we as the crew wanted to know a lot more. And generally we try and get off the ground within 10 minutes of getting a call. Clearly in these situations, that wasn't going to happen. We had to call the referring facility, get some information, some other things that we wanted to know. So we involved, a lot of people in that dynamic. And the pilots, the mechanics, the administration, you needed to have that buy-in to do this and to do it safely for the crew and for the patient. And ensure closed circuit with these mechanically ventilated patients, obviously filters in the right place, clamping the endotracheal tubes when you transferred ventilation platforms, and then obviously the ventilator standby. So again, there were instances where crews would go pick up patients from ICUs, they disconnected from the ventilator. Obviously now you have all that spray from the machine, and it's just, you're exposing a lot of people to unnecessary hazards. So obviously when you go into a referring facility, then you set your ventilator up, get it started, clamp the ET tube, stand by that ventilator, take them off. So now you're standby, put your ventilator on, unclamp, and now you're running and nobody's been exposed. So positive airflow through the cabin. So either the pilot can open up the window or the AC can be running, but we want positive airflow coming through the cabin. We in the EC-145 have a curtain that separates the pilots from the crew. Some aircraft that's not possible, but in our aircraft and our sister programs who fly the 135 have that capability as well. All medical personnel and level 1 PPE. So up here on the right side, this is kind of one of our train wrecks out of a facility that it's about an hour and a half flight. So we have ECMO involved, a lot of drips, and this is not a COVID patient. This is just a regular patient that we kind of deal with. It's kind of our bread and butter. But you can imagine the involvement with somebody like this on all of these accoutrements, us in level 1 PPE in Florida in July and August coming up. It can be kind of brutal. So again, these are, is this somebody that could come by ground? Is it safer to come by ground? Is it better to come by air? And again, this is something that we weigh, and we, obviously the physicians are involved as well, so everybody kind of has to buy in and agree. Pilots in their mask and gowns as well, and then we aeroclave the aircraft after these flights, and that takes about between 30 and 45 minutes turnaround time to get that done. So you can see here on the upper right-hand side, two of my Yahoo friends here in their level 1 PPE. We do not put our PPE over our flight suits. The hospital provides scrubs for us. So if we did get a call like that for a PUI or a COVID positive, we would put our scrubs on, and then we have these impermeable suits that we get from the cath lab that we could wear, along with our hoodies and our North masks that they were provided by the hospital as well. So again, when I talk about the ground perspective and the overwhelming amount of transports that our ground folks did, our first flight for a person under investigation was out of Naples at the end of March. We did not fly a known positive COVID patient until middle of May. So, and again, that goes back to a lot of folks that were under investigation, but they turned out negative. And I think that you guys around the country can appreciate that we're still not ninjas when it comes to testing as a country. So we are still seeing, some testing abnormalities, some false negatives, false positives. We're still trying to iron some things out. And again, I think that's the rarity, but let's be clear. I mean, I think we all know that there are some testing inconsistencies that need to still be worked out, and I think are getting better as we become more familiar with this. Again, 6 by ground, the flight team itself, we had 6 by ground that we did as the flight crew, and then 6 flights. So only the 2 flights were positive patients. Our PPEs come in pre-made packages. So anytime we go on a flight, we use our PPE, we go ahead and we get another package that's pre-made. We have 2 of everything in each package, which is kind of nice. Visor down during air transport, that's the pilots, that's us, unless we have some sort of eye shield and face shield that we can wear. Again, we talked about the scrubs that were provided, and certainly the psychological component to this is just starting to rear its head. We've seen that. We've heard the stories throughout the country of people very, very depressed and doing things to themselves. So our biggest thing is to communicate. We debrief after our flights, and it's dysfunctional as we are, as much as I love my people, we certainly keep an eye on each other and make sure that everybody's doing okay. So far we have done very well, and our crews, all of our ground crews too, everybody has been safe. So that's a very, very positive thing. Nobody has been tested positive for this throughout our EMS system. So my other gig is with a company called Jet ICU. We are a company out of Brooksville, Florida. I've been with them for a little over a year. We are a global aircraft program, so we go all over the world and get patients for medevac and repatriation, and we have some nurses that do commercial assist. We're based just north of Tampa in Brooksville, Florida. And again, I've been to Italy and Brazil and Canada, and I'm sure I'm a familiar face in the Caribbean because I go there a lot. Certainly things have slowed down. Our main folks that we go get are people that are on cruise ships that get sick or injured, but certainly patients that are American citizens that are stuck abroad, we will certainly go get them too. We have 5 Learjet aircraft, 3 Lear 60s and 2 Lear 35s, and we do about 400 flights a year, and they've done about 25 positive COVID patients or persons under investigation. With this company, I think I've done 2. The ISOPOD transport is something that they got a little bit later on in the game. The 2 patients that I had, we didn't have this available to us, but the ISOPOD transport is something that's very, very, very beneficial. It's a negative pressure environment used to contain these biologically contagious patients. It's secure to your portable stretcher, which then of course secure to your patient. These high efficiency HEPA filters that they have kind of filter out any sort of biological substances that might be exposing to the crew. You have patient access adaptable gloves here on the end, and then you've got some pass-through ports where you put IV tubings and ventilator tubing or oxygen or whatever you need. So this is something that has been used as well on the transports that we have with the jet. Some of the issues that we have from fixed wing, the patient transfer to and from the jet is an issue. Stuffing patients through the side door of a Lear 35 or Lear 60 can be a little unnerving for a patient who's awake and alert. For patients who are ventilated, that's probably not a big deal. They don't care, but that can be an issue. So especially if they have a lot more things going on, it can be an issue. International ambulance agencies, truth be told, they are not like your local EMS folks. So we have certainly had some interesting cases for local ambulances when you pick people up in some of these other countries. But I want you to look here in the center. If you follow me on social media, you saw this, I don't know, about 6 months ago. I was down in Merida, Mexico, and we were heading up to the coast to pick up a patient off a cruise ship. And I'm in the back of this ambulance, and I see this Bird Mark 7 IPPB machine with some what looks like oxygen hosing to it or supply hose, and that was it. I was like, why do they have this in the back of their ambulance? And I don't know if it was just for show or part of a museum, but nonetheless, here's this IPB machine, and I have no idea what it's doing back there because there's no circuitry for it or anything like that. But nonetheless, these are some things that you can encounter in your travels. Certainly, there are altitude issues if you're flying at 40,000 feet with these patients that have hypoxic respiratory failure, which is generally these COVID patients. So certainly, you need to calculate how much oxygen that you will need and plan ahead and plan for the worst case scenarios, right? I think if you've heard me talk in the past, you've heard me talk about plans A, B, C, and D, and F if necessary. So crew safety and protection, obviously our pilots are in Tyvek suits and they also have masks and goggles on, so they are very, very careful. Patient access, and that's something else. If you have the ISOPOD in use, you need to be able to know how to get to your patient and to minimize exposure if you have to do that. Second of all, certainly in these situations, you can have turbulence and things that you need to be aware of when you're transporting these sick patients. Family dynamics, that's something we deal with on the jet. You know, if families with these people that are halfway around the world, if they want to come with us, you know, that's a big thing. We were in San Diego not too long ago picking up a lady who had been on a cruise ship and got sick, was in the hospital, ventilated for 20 days, 21 days, and hadn't seen her husband in over a month until we came and got her out, and she came back here to Florida. So it's kind of touching when you have these older couples that have been married for so long, and they hadn't seen each other in almost 30 days, 29 days I think it was, and so they got to see each other, and of course the kids were there, and so it was kind of. And then FBO issues, the fixed base operators, when you go and you land at Tampa International or you land in Fort Lauderdale or wherever, and you have these highly contagious people, these folks in these fixed base operations where you have these, millionaire businessmen and other people coming through, obviously they don't want that exposure. So you need to be cognizant of some of the rules that people have when you drop these patients off, i.e., use the bathroom whenever you can because you are not going to get in there to use it. So briefly a case study and then we'll move on. This is a 28-year-old female cruise ship employee. Came off one of the Holland America cruise ships in San Diego back in late March. She was embarked on the 18th of January, healthy young lady, no comorbidities or other issues. She came to the ship clinic after 3 days of increasing shortness of breath, fevers, and cough. Influenza test was negative. The initial antibody test that they did for COVID came back negative at the end of March. A subsequent test a couple days later, because these symptoms were getting worse, was positive. They put her in the ship's medical ward, for IV fluids and oxygenation and some other issues. On the 3rd, her x-ray is getting worse. This is all the stuff, by the way, this is all the stuff that I'm reading as I'm getting this information from our dispatch at our jet center. This is the information that we're getting off of our medical report. So this is all I have to go by. So everything is verbal or written. I had no pictures or x-rays or anything to look at. So bilateral ground glass opacity is consistent with viral pneumonia. These are the medications that she's gotten. They had a Foley placed. She had some good urine outputs. Her kidneys weren't hit, and she was on a face mask at 6 liters with SATs of 91%. Not bad. But obviously, you know the story that these patients get worse. So obviously, the next couple of days, she did get worse. Worsening infiltrates, O2 requirements up to now a non-rebreather. SATs are still in the upper 80s, respiratory rates in the 30s. She got a little tacky at first, but calmed down. Blood pressure was never an issue. And the ship's doctor describes, and this is in the notes, worsening moderate distress. So this is what I'm seeing. So I'm thinking to myself, crap. So I talked to my nurse. Tyson and I are kind of, we're getting our game plan together. I know how much oxygen I need. I actually took extra with me just in case, because I'm coming from Baja in Mexico. So it's a 4+ hour trip back to Florida. And I did find out that this individual did not tolerate self-proning. So that's out. And they disembarked her from the ship to a local hospital. So she's coming back from CABO to Tampa. And again, I talk about these ambulance agencies that are abroad, maybe not of the same standard that we're used to here in the US, but nonetheless, we get off the jet and use the restroom. We come back out, and I'm hearing that the ambulance is bringing the patient from the hospital. So knowing what I know before, and now I'm thinking, ambulance is bringing this girl. Let's think about tubing her as soon as we get here. I don't want to tube her on the jet, this, that, and the other. So that's kind of what I call the Forrest Gump protocol. You never know what you're going to get when these folks bring the patient from the hospital or from the ship to the ramp where your jet's parked. So sometimes, again, get that box of chocolates. So Tyson and I go to the back of the ambulance. We open up the ambulance, and there she is sitting there, semi-Fowlers, alert and oriented ×4. Looks good, non-rebreather on, of course. She's a little tachypnic. But this is the first time that I had heard the term happy hypoxic. And we've kind of, talked about that now in the past month or so with some of these patients that present this way. Is that, at first we thought we were going to have to intubate everybody. And then we started to find out that wasn't the case. We didn't need to do that. So, again, these are the folks that tolerate maybe a little bit higher percentage of oxygen. There is some talk now of non-invasive. A colleague of mine in Baltimore had folks on non-invasive on an ICU ventilator platform with a dual limb circuit, but they had them on non-invasive, and these patients did fine. So, and that was found, as he was telling me, that was found via a para-intubation code that they kind of found a way to, like we always do, provide oxygenation, positive pressure ventilation with these patients before they got intubated. And maybe they don't need to be intubated because they're doing fine on this mask. So that's how they got left. Anyway, this female that we got, alert and oriented, again, stuffing people into a jet when they're awake and alert can be a little unnerving. So we asked her if she wanted to walk to the jet, which she did. We got the stretcher right up next to the door. She hopped up the stairs, sat on the stretcher, and that 15 seconds, her SATs dropped into the 80s, like 82%, which was just, great. She recovered quickly, though, and an uneventful trip back to Tampa, over to the hospital there. That's her x-ray you can see there. Myself and Tyson heading back to Tampa, and then, of course, she was discharged home. So that's a good story, and she did well. So final thoughts. By the way, the story about the ambulances all lined up. Those ambulances actually went to Executive Airport and picked up the patients that, ironically, were brought by jet ICU from Miami off the cruise ships. And you guys have probably always heard that story or heard the story about the cruise ships having to sit out in the Atlantic for quite some time because they couldn't find a home to port in. Well, they finally anchored in Miami. And I forgot how long it was. It was exponentially long that these folks were on this cruise ship. Jet ICU brought 2 jets down there. They brought 9 patients back, all positive. So our crews are in 2 jets down to the T's, bringing these patients back, land at Executive Airport, offload them onto our ambulances. They bring them over to our ERs. And unfortunately, of those 9, I believe 6 or 7 got intubated, and I think 6 of them expired. And that can be attributed, I think, to them spending so much time on a cruise ship in such dire straits that when we did get them, as one of my colleagues was pointing out, it's just too late, and they got incredibly sick. There is a good story to that. There is one patient that did come off there, was on ECMO, and then got discharged home. There's a really nice story about that. So our final thoughts: appropriate and effective PPE was like the #1 thing when I talked to my colleagues. What's the most important thing to you with these patients? Obviously, protecting yourself, protecting the staff, and then patient education. A lot of times they hear this, I've got COVID and it's the end of the world, and it's really not. So maybe we need to educate our patients a little bit as we start to understand more, is to relay that to these patients. So many unknowns remain, and we have a couple physicians coming up that'll talk about that, I'm sure, but we're learning, and the idea is to keep learning. Again, a lot of you folks, whether you're new to this profession or whether you're, 25, 30-year veterans like myself, you never stop learning, so continue to do that. Vented patients, clearly keep a closed circuit. Don't expose anybody unnecessarily to these contagious, issues and these contagious viruses. Plan accordingly, which I said before. Have your plans in place. And again, having this buy-in from everyone, then communication with everyone. And thanks, Carl Hinkson. Carl's a friend of mine, a colleague from Seattle. And if you've heard Carl talk, they had patient zero up in Everett, Washington back in January, and he's had some great lectures and some really good advice on some of the things that they did up in Seattle. But one of the things that he came up with, and again, I myself and a couple others were like, I'm going to steal that from you. But he came up with staff, space, and stuff. And it's fantastic because having the staff to take care of these patients, and for folks that are in these ICUs across the country, you have these dedicated staffs that are in these ICUs all the time, and then they get very, very familiar, maybe not comfortable, but familiar with their surroundings and the patients that they're dealing with. So having the staff, having the space to take care of these patients, right? Having the ICU space, that's been a big issue. And then the stuff, so equipment, ventilators and filters and PPE and everything else that you will need to take care of these patients. I guess my other thing is welcome to the new normal, and to be safe always. A couple of quick special thank yous. Some of this stuff couldn't have been done without the input of my chief at Advent, Margot, and our EMS director, or our EMS educator, Tim. And then, of course, our director of operations at Jet ICU, Jared Waite, and then my chief there is Mary McCarthy, and they've been very, very helpful in some of the things that we've done there. I'll leave this up there if you would like to get my contact info. Always happy to share some things in the transport world or whatever else. If there's things that we don't know and we can find out together, I'm certainly enjoy being a part of a collaboration to find out the best answers and the best evidence to take care of some of these really sick patients. And that's it. So thank you guys very much. And what is the very somber 4th anniversary of the Pulse nightclub here in Orlando, I wanted to at least extend some thoughts to the people and to the families of the lives that were lost in that. So thank you.
Dr. Morris is the chief from the Division of Pulmonary Critical Care and Sleep Medicine at the University of Kentucky. So we're looking forward to you sharing your experiences with the sudden influx of COVID-19 patients in your facility. Tell us all about it.
I will. Thank you. And thank you for the invitation. Thank you for the Draeger team for organizing this and for the other panelists here. It's a bit of a unique story for a few academic medical centers. Our university has a contract with one of the U.S. federal prisons, one of the medical prisons. And there are a few in the country. They call them an FMC, Federal Medical Center. And just as by way of background, the University of Kentucky is a big regional center for that area. It's over 900 beds. Our base of operation for the medical ICU is 44 beds, but we're never just in those beds. And there's somewhere in the neighborhood of 150 or 170 beds in the institution, and we're always scattered in there. But the experience we had with an outbreak in our prison was one, as you can imagine, that someone had a very large nursing home with ill patients. To give you an idea, I think there's over 1,000 inmates there, and to be in a federal medical center, these people are the sickest of the people in federal care in the prison system. They're multiply comorbid and typically end-stage cancer therapies and organ transplant candidates or recipients. So these are a lot of very, very sick people, all gathered under one roof in very close proximity to each other. It's a sophisticated facility. They have their own nurses and their own physicians, but they are not necessarily at the point where they take care of the high-end acute illnesses there. That's why each of these places tend to have a contract with a university or an academic center nearby. They are leading in many ways, since before COVID, we had many of our clinics engage in telemedicine and deliver health care to the system of inmates there through telemedicine, run by the doctors and nurses on their end and our end in our clinic. So when we had to go to telemedicine in clinics, for many of us, it wasn't necessarily brand new. But across our inpatient system, it was not uncommon to have one or two inmates at one time be inpatients, and even in our medical ICU, it wasn't uncommon. And I'll say one or two things to help preface how our experience went, that there are federal mandates, federal regulations that have to be attended to have these patients cared for outside of a prison. And one of them is that every patient prisoner is accompanied by 2 federal guards. So keep that in mind. And then the other thing is transportation is never communicated. And so this is also a very important point, which I'll bring up here in a minute. One of the things you learn in caring for people is you never discuss discharge date with a person. It's discussed with the prison personnel. And so transportation to and from is, for security issues, always of a high importance. But you can imagine how this might play into how triage and delivery of sick people in a short period of time might play into this. So what we experienced was, overall in Lexington proper and servicing about a 2 million patient area, a slow burn of community COVID positive patients. Compared to the coasts, it was considered minor. And the pace allowed us not to have to activate our usual series of stepwise increase in physicians and nursing. We designated one floor of our medical center that held 32 beds, 16 of which usually operate as ICU beds, but it was designed in a way for these kinds of emergencies. The 16 floor beds on that floor can run ventilators and can be shifted to an ICU. So when we were operating in March to the 3rd week or so, we were seeing about a steady 8 or 9 ventilated COVID positive patients. And with the influx, there was an outbreak that grew very quickly at this prison. Our staff went from handling an average of 8 per day to 28 in a very short period of time. And so that necessitated several things about us moving to the floor and taking over ICU beds, which were usually floor beds, and running not in our usual area. So that was one thing that was different. But you make do. Also, we learned very quickly to become facile at triaging. And triaging was not the emergency room type of triage because of transport. And this is what I brought up before. Because of transport, we would get a very late notice that the ambulance, and it was more like a bus, an ambulance bus, was on its way from the facility. And it was really never communicated the degree of illness for those particular people on that transport. Now, the testing was done at the facility, so we knew that they were positive coming into our facility. We did a few right to the emergency room, and we shifted after about a week, having these patients come right to the ICU. So we were the recipients directly off the transport. So we learned to be very quick in assessing. The volume of people on the transport was somewhere between 4 and 8 per day. They would make one trip. And to give you an idea of how intense it was for a period of time, there was one late Friday where of the 4 people inbound to the ICU, 3 of whom got intubated within 30 minutes of arrival. So the pressure that put on us was not only the logistics of taking care of people with all the PPE and making sure of all these comorbid themes were attended to, but all of the ICUs, for people who are listening in, have capabilities of rapid intubations and quick movement, but we had to escalate it to how many can you do in a short period of time. And so how can you turn over your equipment, your staff, and ready your ventilators? So you might have to go from 0 to 60 miles an hour very, very quickly to support them. The other thing that became interesting in handling these things, and this is something I've heard from other facilities as well, is the frequent need for discussion. Many of these people would wind up on high flow and judging the trajectory of decline. And at each notch, either of the flow or the oxygenation, the respiratory therapists and the staff and the docs would have a conversation of documenting what's the rate of decline of this person, and having a team approach to one more notch down and we're going in to intubate approach. And that worked out very well for us. Overall, of the 60 or so folks that I think have come through, the mortality rate has been in the high 20s. That's not atypical from our usual ARDS mortality that we've been seeing across the year. So it's interesting. The other things we learned were, when we got to the point of having about 28 or 30 out of the 32 beds, doing the math, when you look down the hall with each of these patients coming with 2 federal guards, the crowd control necessary, and they were wonderful, they were working with us, but still having that many bodies and it's a newer hospital, so there's more room compared to some of our older wings. This was a newer wing. It was still quite a challenge, even when you had to transport someone to CT or some other place, that you had to rearrange all the bodies that were in the hallway. Rounds were interesting, HIPAA was interesting, but I think we got through it very well, and many people accommodated these themes. But working around 2 prison guards per patient outside the room became very challenging for many of our usual workflows, but I think you learn very quickly how to take these in stride and move through it. So crowd control was important. At one point, even dealing with the announcement of rounds so everyone could keep their voice down, because it got to the point where it was very hard to hear at some points, even with a low murmur conversation from 40 or so federal guards in the hallway. But they were very respectful of us trying to move patient room to patient room and have a serious discussion and assessment. So those were our experiences. I think the input I would say that we learned is to have deployment plans, triage plans beyond our usual. We would never see the rapidity of having to intubate this number of people in such a short time frame. We didn't know when they were going to arrive or the density coming in because of certain security themes. So you just stayed prepared and planned for the worst. And the good things that came from this was the frequency of discussions and reassessments that were necessary in someone who was in their pre-intubation phase. We had a few who went right through and never did require intubation, and they got up to a certain level of high flow and then walked back from the edge. But those who continued within, say, hours of notching up on their high flow needs, that trajectory got everyone's attention, and the planning became such where, handing off even from day shift to night shift, we would be marking out the number of times the high flow had been increased with the threshold cut for this person. If this is reached, the recommendation is to go ahead with the intubation plan. So I hope everybody has those types of plans in place. I would not hope that someone has those experiences, but for folks who have nursing homes in their areas where a quick number of people might be exposed and get sick simultaneously, and assessing for those, there may be similarities in your planning as to what we went through. And at that point, I'll say thanks again to the Draeger team and to Ed for inviting me. And if there's any questions, either now or whenever you say ready to go. And thanks again.
Yes, absolutely. Put your questions in the question window. That would be great. I do have one question that's come in for you, Dr. Morris. So I'm wondering, do you have any thoughts on the perspective of putting multiple two patients on one ventilator when inundated with the numerous amount of patients that you had? Was that
Luckily,
ever a thought?
I think very, very briefly, and then with the exploring those possibilities, I'll say one thing that we did explore and got to at one point was having the rooms in this wing are designed, and they were very large, and the plumbing on the 16 typical ICU beds could take 2 ventilator setups, 2 beds inside the room, 2 series of monitors. And we did that once or twice just because of the need for cohorting and where things were on the floor. But no, we didn't have to get pressed for the need to consider 1 ventilator for 2 patients. The flows issues, the need for control of protection from cross-contamination, those kinds of themes from the literature and from what we could get from our respiratory therapy experts, we never felt comfortable moving in that direction if we needed to. Luckily, 2 things that in our area just came through. We work closely with a chronic ventilator hospital that had a series of ventilators in store that were on loan to us. And we work closely with a community hospital respiratory therapy school who also had the need to teach their students across a wide variety of mechanical ventilator companies and models. And so we had access to another cohort of ventilators there. So our fleet levels never were threatened, luckily, but I can imagine that's a question that comes up for many people who didn't have access to the numbers of ventilators that we did. So, but we did not have to entertain that beyond the chalkboard theoretical.
Okay, great. Thank you. Another question came in. Did all of your patients with COVID-19 require supplemental oxygen?
I would say now that at the beginning, yes, because of the acuity and the triaging, very few were admitted without oxygen. What we're seeing now, many of the institutions in our region have gone to universal testing on admission, and we're seeing asymptomatic positivity. So people come in with a GI hemorrhage, I'm here for a bowel obstruction, and oh, by the way, I'm COVID positive. Clear chest x-ray, no respiratory symptoms, no oxygen needs. So that's become a challenge, keeping up with those patients' needs, and going to operating theaters and operating rooms has become with the frequency that we're seeing, it's up and up and up. So it's becoming like the universal problem now. We have to have that availability and capability everywhere in our institution.
Good, good. And one other question I have here is, do you use heated high flow nasal cannula in your treatment? And if you do, what was the maximum liter flow to prevent any sort of aerosolization or cross-contamination concerns?
Our nasal cannula was traditional. Our high flow was such where 100% and 60 liter operating. Our PPE was such with our negative pressure rooms, that we could apply our high flow with a high degree of the sense that we were safe to our staff. So far, none of our staff have had a positivity themselves. So knock on wood, we've been lucky in that regard. The coordination of the care of these patients, I would say one other thing locally, and I think nationally, it has put our colleagues who are such great caregivers, our respiratory therapists, more in the spotlight. And I think more and more newspaper pieces and magazine pieces have been brought to shine light on our colleagues who have been trained as a respiratory therapist, who they were just leading the charge here, and they would be in the room as much as anybody else and would be leading our assessments and leading our delivery of these devices, and were very much a part of the decisions to move from, say, a high flow to intubate.
Right, right, very good. So a couple more questions have come in. I'm just going to continue on. We've got a few more moments. So one person writes, I hear the secretions are very different. I hear that they are sticky and a very different consistency than what we may be used to with other diagnoses. What's your thoughts?
We saw a spectrum. I would say somewhat from very dry acute lung injury to minimal scant white secretions all the way through to yellow thick secretions, but nothing that we could predict, even from knowing the comorbidities underlying if someone had severe end-stage emphysema. It wasn't something that we found, maybe because of the smaller volumes overall compared to what the folks on the coasts were experiencing. I couldn't estimate for you any predictability or a routine COVID positive pattern.
Sure. Okay. And one last question before we move on. Are any of your positive patients currently that may be non-intubated patients, do you have them in any non-negative pressure rooms?
No, we were lucky enough to have sufficient working in a facility that had a recent build. The negative pressure rooms were quite multiple, and so we've not had that situation come up.
Very good. Well, again, Dr. Morris, thank you so much for joining us today. Dr. Daxton, it comes from the Mayo Clinic, anesthesiology and perioperative medicine. We're lucky to get the opportunity to listen to your journey and to your experience as a physician who decided to go ahead and volunteer.
There. All right. Again, my name is Ben Daxton. I'm an anesthesiologist intensivist at Mayo Clinic in Rochester, Minnesota. Before I say anything, just wanted to say thank you to Ed Coombs and the team at Draeger for the invitation to speak, for facilitating this despite all the technical glitches. Those are all on my end here, nothing on their end. So I take full responsibility for that. So the need. Can you all still see the screen as I'm sliding through here? Okay, so the picture on the left is from the best man at my wedding the weekend before I went. That man is Jonathan Davis. He's an outpatient med-peds guy in Georgia, and his wife had shot me an email while I was working in a tele-ICU to let me know that he had gone to volunteer in New York. I was a little shocked because I hadn't heard about him even considering going. He was not an ICU guy. He was not a critical care guy. He had no ties to New York, and he had 5 kids at home. You can see some of them in that picture. So I immediately gave him a call because I was literally sitting in an ICU where my job was to answer critical care questions for people who were not used to taking care of critical care patients. Perfect setup. Best friend. Here I am, ready to help. And I gave him a call, and the first question he asked me was, what do I do with Pete? And I thought, oh boy, we're in for a long, hard slog here. So the stories that he told me then were just horrific. Whatever you heard on the news, it was much worse, at least where my friend was. He said his first night, he probably averaged about 3 codes an hour. So if you imagine a code's 30 minutes, you can't do 3 in an hour, and he did that every single hour times 12. That hospital where he was normally had 5 ICU beds. Sunday, April 19th down there, they had over 100 ICU COVID patients. They had over 70 FEMA ventilators brought in. The hospital was just overwhelmed. That day, the first day of my friend being there was the first day that they had a ICU physician in-house. The hospital did have one, but unfortunately had left a month prior, and the one other one had actually come down with COVID himself, and so they were without a critical care physician trying to manage all this. At the same time, so I had this horrible conversation with my friend. I was trying to help him out, and when I got off the phone with him, I went back to my tele ICU, and at that point, we had 3 COVID patients in our ICU, and we have 200 ICU beds at Mayo. I mean, we had nowhere near the influx that they did, and the nurses were figuring out how they were going to go about with furloughs that had just been announced that day, and so the contrast was pretty stark. And so I went home and spoke to my wife. First of all, that had to be conversation number 1. And we decided that this was something we needed to do. I then spoke to Mayo Clinic and the various administrative people that were involved. You can imagine this was back when we didn't know what was going to happen. The sky was falling, and there wasn't a lot of excitement about giving up critical care physicians when we could be next. But I was fortunate enough to have the support of those above me. We worked out the logistics. I had a free flight from United. The hotel donated a free room for me. So the logistics were taken care of. One of the reasons we felt I was okay to go was my family had been through this before. I was previously on active duty with the U.S. Army, as you can see there in the middle. We knew what it meant for me to be gone for an extended period. We had wills in place, things like that. So we felt we were in a unique position to be able to go. And then lastly, I'm a Christian. My faith informs a lot of my decisions in life. The Heidelberg Catechism is part of the core of my beliefs, and that had a big impact on what ended up moving me to go. So preparing, you can see there on the left, that's probably the weirdest packing I've ever had for a suitcase. I had my iPad with all of my notes, all of my PPE gear. I had my butterfly pocus. I had my own Sani wipes. I don't think I'll ever pack quite like that again. And then the airport there on the right, if you can't see anybody else in the picture besides me, that's because there's not. Not a single other person was in the airport except for 5 other people on my flight. I've never gone through security so fast. Personal protective equipment always comes up. So I did bring some of my own. You can see there on the left, I'm wearing a scuba mask. So I'm actually in the hospital in New York there. That is a scuba mask that I have a buddy at Mayo who's in our 3D printing shop, and he 3D printed an adapter so I could put on a viral filter. You can see on the bottom of the mask, that's at the end of the day. It's just condensation. It was hot, it was suffocating. Unfortunately, I couldn't talk, so I had to just revert to normal N95s for the rest of the week. There in the middle, you can see that was their PPE supply tower walking into the unit. It's exhausted. It was a scavenger hunt every time to find the equipment. The guy on the far right was just somebody on my flight, and I felt people on the plane randomly had better preparedness for working in an ICU than a lot of us did, but we made the best with what we had. So this was the unit I went to work in. I ended up not going to the same hospital where my best man was. As you can see, it's not an ICU. So the hospital where I volunteered normally had 3 ICUs. They made 3 additional ones. This area, these 2 are shut when you're going in or going out. It's just curtains that you pull. I had all these grand plans about how we were going to don and doff appropriately and adhere to strict PPE guidance, and we were going to be very strict. And there's a famous Prussian general who has a quote, again to go back to my military days, that no plan survives first contact with the enemy, and that was certainly true for us. Things were just getting disconnected left and right, and no one really seemed to care, because in this environment, it didn't seem to make a difference. You were exposed no matter what you were going to do. So when I got there, these are some of the problems that I saw. I'll see if I can get this to play. It may not, which is a shame. This was a ultrasound that another fellow I worked with one night had taken. This was actually not one of my patients. This is not my hospital. You can kind of see in the middle there, that's the IVC going in the right atrium. And in the very middle, there's kind of a white ball in the right atrium. That is one of about 4 golf ball sized clots in the right atrium. that were just jumbling around like ping pong balls. And about 15 seconds after they quit taking this video, the patient abruptly coded, as you can imagine, from a massive pulmonary embolism. So these patients were unbelievable. I'm not sure if you all are saying the same thing at your hospitals, but the anticoagulation conundrum was incredibly frustrating. So that patient right there with all of these massive clots, that patient had developed those already on full dose Lovenox. I did not have a single patient with a dialysis catheter who did not need a dose of Alteplase at least once a day. In fact, into the right ventricle just because it has more turbulent blood flow and was less likely to clot off. Mostly respiratory therapists here, so you may not appreciate it, but that's nuts. You don't put things in the right ventricular holes, but they felt that the risk was worth the benefit. Here's probably what you're more interested in, the ventilator issue. So the hospital I worked in definitely did not have enough ventilators. So we got tons of these FEMA LTV 1200s. Oh, I think I have the 900 up here, but for practical purposes, it's the same. And sorry, your careers, I had to use these a bunch when I was deployed in the military. Those days when I go back, a challenge. The unit where I was, things had kind of slowed down in New York City. So they had tried to not admit any new patients to my unit, and mine were kind of the long-term patients. So most everybody there, except for 2, had been intubated for at least a week, more likely 2 or 3. So you can imagine being on an LTV for 2 weeks with COVID, your lungs are a shredded mess. I frequently had patients with a PEEP of 20, a driving pressure of 20, and tidal volumes of 4 milliliters per kilogram, and they had CO2s through the roof. I mean, it seemed fruitless no matter what settings we adjusted. With one exception, there were 2 patients that did actually remarkably well on the ventilator. And to the right is a note of one of the patients. I had a conversation and he wrote scared, you can see at the top. And after we talked for a little bit, he wrote the air is good now. And the point I made when I showed this to some of my colleagues is that I think we overthink a lot of our medical management, and just simple humanity goes a long way. This was a young guy, 39. He was just a few years older than me. And I felt a connection with him. He didn't have any medical issues before COVID, and he was very scared he was going to die. And I just sat there for 20 minutes and we just talked as best we could through tube and notes. And at the end of it, he said, "Bear's good now," and he felt fine. And I didn't change his vent. I didn't give him any meds. I think it was just the fact he had someone to talk to made a difference. So if you leave my talk with one thing, it's take an extra 5 minutes just to try and be a person for your patients. They don't have family members, I'm assuming, visiting as frequently as they normally would without COVID. The other thing, though, that might interest you is that when he wrote that, the air is good now, he wrote that while he was on APRV. I said I had 2 patients that did very well, and those 2 happened to both be on APRV. And the air is good now, he wrote that on a P high of 34. So I'm not going to get into the detail that people would believe me if I told them I had someone writing notes to me on a CPAP of 34 with COVID, but it does happen. One of the other problems is the dead space ventilation in the lungs, the VQ mismatching. And so I had one patient who'd been intubated for 18 days, and you can see to the far right, his CO2 had climbed to 104. That was actually down from the day prior when it was 156. We had done everything we could to get it there. So the 104 is on a minute ventilation of 16 liters a minute with Tylenol and cold packs and everything else we can do to try and decrease his CO2 production. But this guy started needing more vasopressors, his urine output was dropping, and we could just tell he was starting to circle the drain. And I thought, you know what I would really love to try would just be some nitric oxide. But we were out of nitric oxide. We ran out a long time ago. But when scarcity and necessity meet, ingenuity comes. And so we ended up taking kind of a bastardized form of nebulization here, hooked up a little device. I'm sure some of you can see it there. It's kind of in the background, blurred out. Forgive me, I don't remember the name of the device, but it nebulizes medications. And we didn't have any nitric oxide, so we took nitroglycerin sublingual tabs that you would give for acute coronary syndrome, diluted those into. We took 3 of those tabs, diluted them into 3 milliliters of normal saline, put that in the little vial, put the cap on, and said, "Here goes nothing." And you can see up at the top, we took this guy's CO2 without any change to his ventilator or any other new medications from 104 to 60. And we thought, oh my gosh, that actually worked. We got to keep doing this. This is amazing. And so we were able to find some actual IV nitroglycerin. I went over to the OR and grabbed a bottle of this. We spiked it, and through a dripper you'd adjust manually, we figured out what the rate would be to keep a constant level in that nebulization chamber, and we made our own nitric oxide infusion for this guy. This is not standard of care. This is not how medicine normally goes, but you know, we were doing the best with what we had. And I'll say I don't know if it ended up making a difference in this patient's care. I left and he was still in the ICU several days later. But if nothing else, it gave everybody in the unit a little bit of hope. This guy was heading in the wrong place fast. And for a brief moment, we righted the ship. And we felt like if we could pull that off, maybe we could pull off some other stuff. And not everybody was a lost cause. So yeah. These are some of the people I worked with. This was a wonderful and frustrating aspect at the same time. No one once complained. Almost everybody there was a fellow who had no critical care training. The picture on the left, I've got a GI fellow and a cardiology fellow. They never thought they'd step foot in an ICU again, at least to run it like they did when they were interns, but there they were. The woman to my right is a ER physician who had been there 19 nights in a row. I don't know how she did it. The group on the far right, that's day team, night team, sign out, ragtag group, but I go into battle with any one of them all over again. They were, again, absolutely fantastic. But the time there took its toll. That's a picture of me there on the left. You can see my nose is a little red. Wearing the N95 every day for long shifts. I actually was at lunch with someone the morning after my last shift, went and grabbed breakfast, and I took my mask off to eat, and I didn't even know it, but I had all this blood dripping down my nose, and she had to give me her napkin so I could wipe my face just to eat my food. The picture on the right there, you know, I told you some of the stats of the hospital where my friend was. I'm not going to tell you too many of the hospital where I was, again, just for their privacy's sake, but those are note cards from the infectious disease consultant. He counted them up. I want to say he had like 47. You know, every one of those is a 20 to 30 minute review, and he does that every day, weekends, weekdays, and he'd been doing it for over a month. The guy was in his 60s. He was just getting crushed, absolutely crushed. So I don't know how much good I did for the patients, but I worked all the night shifts while I was there, and I know I at least gave a lot of those guys a chance to go home and have dinner with their family. And if nothing else, I'm happy just to be able to provide that. So processing it all. This is a little weird for me. I initially would just post things about what happened to me on my Facebook page just to kind of update family and friends. You know, I'm going into the epicenter of all this, and people were nervous about my health. And my brief posts became longer and longer and longer. And I found it ended up being very cathartic for me. I would finish my night shift, go grab breakfast, walk home, write my thoughts. And I was surprised how helpful it was for a lot of other people. You know, I live in the ICU. It's what I live and breathe, and I think about it all the time. But people outside of the ICU really don't understand what goes on in the ICUs. I'm sure you know, you all can attest to when you have families come in and you try and have conversations, and they don't appreciate the gravity, or they ask for procedures, and you know, they just don't realize the futility of what they're pursuing. And so I was surprised how helpful it was for people to read what I had gone through, and for them to kind of understand what they were seeing on the news. So through friends of friends, my Facebook ramblings got picked up and published on a national news website. And through that, Ed found out about me and gave me a ring to come and speak here. I don't say all that just to say I got published in the news, look at me. I say that because I spent a lot of time thinking through those posts, and especially now when I found out that they were going to be put on a national display. I will say it's a little nerve-wracking to have your ramblings after a night shift suddenly be projected to, you know, millions of people, and you cringe at all the typos and grammar errors. But anyway, the point of the slide is I was shocked for my own benefit the power of writing it out, of talking about it, of doing things like this. I've given a couple talks to our fellows, and I'm slated to give anesthesia grand rounds next week, and it's been very helpful for me. I have a lot of bad memories from my time there. I think I could have done things differently, and by differently I mean better, and it gnaws at me, and it's hard to spend a week in a unit to devote so much, to sacrifice so much, and walk away thinking I could have done better. And being able to write those feelings out and discuss them, and they are discussed. It's not just writing them, because as soon as I write them and other people see them, then they want to ask, and I'm forced to actually confront what I put on paper, has been remarkably helpful for me. I think there's going to be a lot of PTSD from everybody involved in the healthcare field who's been in part of patients' care. And if you get a chance, please write it down, find someone, talk to someone, even if you're not a writer. I am not a writer. I'm an anesthesiologist. I went into anesthesia because I get to scribble stuff and I never have to write anything. It was a wonderful career decision, but writing has been incredibly helpful for me, and I encourage everybody to try it out. And that's my brief foray into the COVID ICU in New York, and I'm happy to take any questions.
Well, I first want to say thank you. Thank you for your service previously outside of the U.S., but I know that many of my colleagues, especially Ed Coombs, and those that are in the New York area, want to thank you so very much for your commitment, your compassion, and your willingness. I can't express enough to you, Dr. Daxton. Thank you.
Yeah, thanks.
We do have a few questions that I would like to go through right now, if you don't mind.
Sure.
Yeah, it looks like, so curious. Did you have any patients that you did happen to use BiPAP on COVID, those COVID patients? Did you use any BiPAP modes?
I never used BiPAP. I used CPAP for one patient. I don't want to get in the weeds of BiPAP for CPAP. I didn't want the pressure support for my guy. I thought he had good compliance. I just thought he was suffering from malignant atellect trauma. I'll put it like that. So I thought CPAP was a better route for him.